So thank you very much, Dr. Subieta, and the organizing committee to invite me to tell you something about my experiences, our experience with the that's how we perform the fusion biopsies transperineal. It's an honor for me. After all those excellent speakers, I will repeat, of course, a lot of the figures you already heard. My opinion about optimal prostate diagnosis and treatment is that we should try to get maximal information about tumor aggressiveness and tumor growth. And unfortunately, we heard it already, this is not achieved by the regular ultrasound-guided transrectal biopsy procedures. But those two important items can be solved using a diagnostic multiparametric MRI in our experience. I will tell you how and why we use the MIM software with transperineal biopsy of the prostate using fusion. Why did we choose for it? Excuse me, I need a little bit. Why did we choose for it? Some figures. MRI is discriminating in our opinion. We performed, in my former position, over 800 multiparametric MRIs in patients that were under active surveillance. And we found a 24% to 25% higher grades or multiple tumors or even extraprostatic growth. At Andros, we can have all our MRIs in the expert center of the Radboud Hospital with Jelle Barends. We saw his name several times, and we are very lucky that we have that. In the Netherlands, we have we make almost 40,000 biopsies a year, and there is a detection rate of almost 30%. It's what we heard before. But this causes more than 2,000 infections. And due to the increasing number of resistant E. coli, ultimately it's leading to sepsis. And sepsis is a life-threatening situation, in fact. And this will happen more and more frequently in the near future. So these were the main reasons for us at Andros to change to the usual US guide biopsies through the rectum, and it causes less infections, no infections in fact up to now. We don't give any antibiotics anymore, and less deformation of the prostate due to the parallel movement of the probe, resulting in a more precise fusion. So let me tell you something about MIM. Short description. MIM software is the pioneer in image registration and fusion in many organs in the body. It has nuclear medicine products for SPECT and PET-CT fusion. In cardiology, they have image registration. In neurology, they have registration using PET and SPECT. And in radiation oncology, it has brachytherapy solutions and also registration for brachytherapy and external beam. So they are used to fuse and to match. And now the MIM software is used at many sites and is expanding in collaboration with many others. And this expertise is brought now into the fusion biopsy field with innovative and unique tools, and they call it Symphony. And the name Symphony symbolizes the collaboration and the multiple instruments creating a harmonious outcome. So, Symphony offers you a complete solution. After performing a multiparametric MRI, Symphony includes a Symphony DX, that's for the radiologist. It's offering him a PIRA scoring system, a reporting system, and tools for contouring the suspicious lesions and registering the prostate image correctly. And he has for that the reslicer tool. I'll tell you about that later. It includes also the Symphony BX. Symphony BX is the instrument for the urologist to do the biopsy, using these fusions with the registration and contours of the radiologist. And when the pathology has reported the lesion score, you can make a clinical pathway using all these optimal tumor information leading to any treatment, active surveillance, surgery, radiation, with brachytherapy, external beam, and so on. So let's go to practice. As I mentioned, one of the big advantages is the MIM reslicer, we call it. This is a unique tool. It was, for me, a differentiating factor comparing the other systems. The issue is that the images are reconstructed in a different orientation. You can see here. The patient laying flat on the MR table, and the ultrasound images are acquired in the lithotomy position with the legs in stirrups. And the reslicer works by mimicking how the ultrasound probe is positioned during the biopsy. On the right you see the ultrasound image where the probe is placed parallel to the posterior wall, and the image is acquired perpendicular to the probe. It's represented by those green planes. On the left side you see, it's not, oh, you can see it. You can see the images perpendicular to the table. So the radiologist can position now the reslicer on the MRI images in the same orientation, parallel to the rectal wall, and you can see the probe sliding parallel to the posterior wall, and the software reslices. The software reslices all the images, matching the ultrasound. So you can effectively predict the alignment of the MR and the ultrasound images. So there is no intra-op contouring during the biopsies. It will not slow you down, and you just can match the prostate outlines and begin take your course. I call it intuitive, and intuitive is for urologist a name they hear very often, I guess. So these are the ultrasound captures and the resliced MR images. And you can see here the matched contours of the prostate, urethra, the suspicious lesion, and also the rectal wall. So it's very handy and fast. So what are the advantages of the MIM Symphony system as we think? It has an excellent user interface. It's easy to use. And wherever the contour is drawn, it's projected in all the MR sequences for the radiologist. You can also go back to your MRI during the biopsy procedure to see if there is something you didn't expect. They offer a customized workflow, step by step, defined and formed at your own wishes. It delivers synoptic reports. The transfer of the data is very comfortable. And you don't need to buy an extra ultrasound machine. If you do brachytherapy, you also have already a stepper unit, so you only need your software. So why did we choose for the MR TRUS fusion biopsy transperineally? I already told you, transrectal biopsies have shown up to 7% infection rate and then around 1% sepsis. The whole prostate can easily be reached. The reslicing means that you have more precise tumor location. The stepper with the ultrasound probe is fixed on the table, and you use a template grid, same as in brachytherapy, if you know that. So you can have a precise placement of the biopsy needle. It's a fast procedure. We do it in 30-35 minutes, including the local anesthesia, because we give all our patients a local anesthesia for the biopsies. And it's easy to learn. It's excellent guidance by the MIM company. 24 hours a day they have a help desk, and maybe it's also the cheapest. So this is our treatment room. It's the B&K Flex Focus, the track stepper over here, and the software system. I would like to finish with, don't show you all the methods of the contouring and the biopsy, because you can see it outside. I saw the nice demonstration over there, so because of the time I did skip it now. So I will show you some results we had now with the fusion system. In 150 MRs, we did 60 procedures for the biopsies. It's 40%. That's because it was a pilot 3, 4, or 5. You can see the figures here. The outcome, if it was a pilot 3, only very small numbers, there were no malignancy in half of them, and the other were mostly low grades. But if it was a PIRES 4 or 5, we had 7 benign biopsy outcomes. The pathologist said it is an active prostatitis, and sometimes 2 times it was a glandular prostatitis, and it can be difficult to see that on the MR. But we had 50% high grades. So we found 30% prostate cancer in those 152 men with originally suspicion for rising PSA, elevated PSA, and they all would have normally undergone regular biopsies. And if we look at the visual analogic scaling discomfort, we asked them to scale between 1 and 10 for the pain and the discomfort. We see that for the pain regarding the subcutaneous injections for the anesthesia and the injections along the neurovascular bundles, it was a bit uncomfortable. Score between 1 and 5, and the median was 3.1. But for the pain during the biopsies, it was only a median of 2. So they all said afterwards, I felt it, but it doesn't matter. Conclusion, the future as we see it now. For all our patients, if there's an indication for a biopsy, we first will have a high quality MRI. And the indication for a biopsy can be a PSA rise, a Quattro test, a 4K test, biomarkers, and then we do an MRI, a multiparametric MRI in an expert center. If there is suspicion on the MRI, PIRES 3, 4, or 5, we do only the target biopsy. If there were early, within 6 months before, if there were negative biopsies, we only do the target biopsy, otherwise we do also random biopsies. We think that we can have a very nice active surveillance with MRI if it is an insignificant lesion. 7A means 3 plus 4, 7B is 4 plus 3. With the MIM system, you can easily put all those MRs in the sequential, after a year, after 2 years, you can put under each other and you can easily compare them. If it's a significant tumor and it's only 1 lesion, probably we can go to focal therapy. And then we can use also the imaging with the Symphony bikes for radical treatment. Or we do a radical prostatectomy or a radiation. The follow-up you can do with MRI, and you can do targeted biopsies also with Symphony. So I hope I didn't take too much from your time. Thank you for your attention.